Discussion on David Fincher 7. Any particular character, scene, or plot device that we'd like to begin our discussion? There's no wrong answer.
I suppose we could. The most poignant scene to start with, I guess, would be the scene in the car when he's talking about Mills.
So what's anybody's recollection on the discussion between Detective Mills and John Doe in that car? If you're a passenger in that back seat with John Doe, thoughts, feelings? You comfortable, uncomfortable? You enjoy it? You wish the car ride were 3 hours longer?
I mean, it's. Was someone else talking? Okay. I mean, it is interesting to see how he, in one sense, he talks a lot about his mentality regarding as to why he chose his victims and why the seven sins was such an important factor to him. But at the same time, he also seems to show a lot of signs of, like, for example, when we talk about patients with MPD and how they tend to intend to engage in transference with the therapist. In this case, I think, Mills, the person he admires, ended up being his therapist in that metaphor because he was testing, Mills's viewpoints and saying that we're not too unlike one another, and he was essentially trying to get Mills to react in the sense that he wanted.
Also not unlike a psychotherapy appointment. There's a conversation between Mills and John Doe. There is a reference per Mills to his being delusional or psychotic. So there's an element of grandiosity. So I need the group to convince me, one or the other. Is the grandiosity part of a mental disorder other than psychosis, or is it delusional disorder grandiose subtype? So there's different reasons why people could be grandiose. First and foremost, it could be completely normal. Right? Any one of us could have that episode. However, it could also be abnormal. And if abnormal and it results in clinically significant distress or impairment, it could be disordered. So now we have to consider what disorder then would be fitting for our patient, for John Doe. So we think of delusional disorder, grandiose subtype. I think that's where the conversation begins. And if collectively we decide no, then we could broaden our differential diagnosis to include non-psychotic disorders. So first and foremost, what is delusional disorder? And Mills brings this up. I think he may use the word delusional. Delusional disorder is defined by?
One or more delusions.
Stop. Perfect. That's it. That's it. It gets that easy with the APA. You nailed it, right? Yeah. That is by far the easiest way to remember delusional disorder. Now, again, we mentioned the word disorder, which means that by definition, the delusions must be clinically impairing, must result in clinically significant distress, or impairment in functioning. So that goes without saying, right? Next question is, if you're telling me that we have a character that is delusional, it sounds to me that you're telling me that John Doe has schizophrenia, no?
Not necessarily.
Oh, now you're going to have to convince me. I'm confused. Tell me more.
So then, in order for someone to be considered schizophrenic, they need to have symptoms for upwards of 6 months of several positive criteria, which would include some sort of illusions, hallucinations, or disorganized speech. Those are the positive symptoms you can get. At least one of the criteria that you have for those three has to come from one of those positive options. And then the negative ones are either they might be speaking less, they might have less eye contact, they might have fewer, just less interaction in general. And so they usually fall into the negative criteria category. So then I guess if we wanted to diagnose them with schizophrenia, we need to check for those as well.
So are you telling me, and not to put words in your mouth, that delusional disorder may present looking like schizophrenia, but that the individual will not meet full criteria for the condition of schizophrenia?
That checks out.
Right? So delusions are shared between these two diagnoses. The additional criteria that defines schizophrenia, and you only need two total, include those perceptual disturbances, the disorganized speech or thought process, the grossly disorganized or catatonic behavior, and then any negative symptoms. Now, with regard to those other four that are more specific to schizophrenia, and by the way, schizoaffective disorder, does John Doe demonstrate any of them?
No.
Right? Doesn't seem like it. So it does look like this is going to be delusional disorder, at least having considered schizophrenia. Right? So that's one of the things that you have to consider with delusional disorder. And we see this with multiple mental disorders in general, and that is that what you're focusing on cannot be better explained by a larger, more comprehensive healthcare condition, including schizophrenia in this case. Right? Anybody pick up on any perceptual disturbances? Grossly disorganized or catatonic behavior? No. His behavior seems very premeditated. It's anything but disorganized. It's very organized. And same for his speech and thought process. I mean, his thought content does demonstrate evidence of, or the presence of delusions, but the thought process is fairly linear and otherwise not disorganized. Before we leave this topic, and that is the definition of schizophrenia, we listed those four positive symptoms, those four symptoms, the presence of which are pathological. So positive symptoms means the pathological presence of signs that at baseline should not be there. Right? There's four of them that define schizophrenia. Tell me what causes them neurobiologically. Give me the neurotransmitter. Dopamine. Is it a relative or absolute excess of CNS dopamine?
I don't know.
Yeah. That's because we probably don't know. But we say absolute. Yeah. Relative, we get more in delirium, but the lines are not firmly delineated there. All right. But for all intents and purposes, we'll consider it an absolute increase in CNS dopamine. Now you're going to give me the dopamine track that would explain the positive symptoms of schizophrenia.
That means Olympic.
Right. Flip now to the negative symptoms, any negative symptom. The pathological absence of something that at baseline should not be there. Right? Or sorry, at baseline should be there. Alogia, absence of speech, should be there at baseline. Neurotransmitter?
Also dopamine?
Too high or too low?
Too low.
And now tell me the track.
I have broader cortex, but I'm not sure where.
I'll give it to you. Mesocortical tract. Yep. Comes up on shelf exams. All right, so thank John Doe when you fill in choice B, get it right, ace your shelf. Back to John Doe. What else do we say?
Seems to have kind of an inflated sense of like self-worth or self-responsibility. Sees like his actions as like society doesn't account for negative behaviors, so he feels that it's his duty in a way to kind of correct that.
Yeah, and the focus on his perceived duty is what I think buys us the clinical significance. It's one thing to think that you've got this special gift that's bestowed upon you. It's another to act on that gift, especially in the fashion that he does. Right. So, very consistent with delusional disorder, grandiose subtype. What are the other subtypes of delusional disorder other than grandiose? Let's say this guy is 5. He has 4 SIBs. What do each of them have?
Somatic,
Somatic subtype?
persecutory,
2 more.
Erotomania.
Good. Jealous. Now, there are conditions, there are delusional themes that do not neatly fit into one of the top 5, so that goes into an undifferentiated subtype category. It is very unlikely that your single best answer on a shelf exam will be delusional disorder, undifferentiated. You're not likely to see that. However, there are some more common undifferentiated delusional disorders that go by proper names, and you will likely see. Any examples?
Like the Capgras delusion?
Yeah. So Capgras 1. Somebody explain what Capgras is? The delusional belief that blank.
Is it this when your loved ones have been like replaced, or people around you have been replaced by aliens?
Or imposters.
Imposters.
Yeah. Yeah. My favorite's an alien, but not everybody shares my sentiment. The imposter syndrome. Or if you want to be alien themed. Anybody here sci-fi horror fans?
Yeah.
Yeah.
Over here.
My N of 1. This would be the body snatcher syndrome for the alien horror film fans. I got one now. Cool. Very cool. All right. Another example of an undifferentiated type of delusion or delusional disorder. What is the Cotard syndrome?
I believe that like a part or full body is dead.
Right? Decaying or dead in some way, right? Mm-hmm. So the Walking Dead syndrome, keeping with our horror theme, this time zombies. And then finally the Fragoli syndrome, which is considered to be a variant of of Capgras. Fragoli. The delusional belief that a person or entity can shapeshift. Right? So the shapeshifter syndrome. All right. Any questions about delusional disorder?
Can you name the differentiated subtypes again for delusion disorder?
The undifferentiated?
The differentiated, like grandiosity subtype.
JPEGs. So the acronym is JPEGs. So it's jealous, persecutory, erotomanic, grandiose, and somatic. So we're thinking grandiose? Right, grandiose subtype. Anything else going on with John Doe? So let's just review the signs and symptoms, the diagnostic criteria of antisocial personality. We're going to see this come up, I think, in the other 3 weeks of your clerkship, because we're going to be watching films in which we're going to see characters that have a blatant disregard for and violation of others' rights as a cardinal feature. And with that cardinal feature, very top of your differential should include antisocial personality disorder. This condition, antisocial, is diagnosable in anyone 18 years of age or older. It should be reserved for only adults. In addition to identifying that this is an adult-only illness, the individual must also have evidence of conduct disorder prior to the age of 15. Whether that's been formally diagnosed or not is a non-issue. They must have evidence of conduct prior to the age of 15 years of age. This is one of the 4 personality disorders that can or tends to remit with age. Anybody want to take a guess at what the other 3 are? There's some clinical improvement with age.
Borderline personality?
Yeah. Yeah, there can be greater stability in relationships in the 4th and 5th decades in borderline personality, especially if what form of therapy is provided.
DBT?
Yeah, and that comes up with regard to a question stem of what the empirical evidence is with regard to successful outcomes in borderline. It's DBT is the single best answer. Right? 2 others that can or tend to improve or remit with age. Yep, avoidant personality disorder. Yep. And one more that is clustered with and therefore related to avoidant personality.
Obsessive compulsive.
That's the other cluster C, but it's not that one.
Borderline?
That's cluster B.
Oh yeah.
right? Dependent personality disorder. The individual who requires reassurance of their every next step and only proceeds with significant stress if not reassured. Right, so that's dependent personality. All right. Further observations, John Doe.
Would you consider like an OCPD just because of his like meticulous planning, his moral rigidity, things like that?
Yes. Yeah. I would really, well, it goes without saying, I would really, really be intrigued about understanding his early childhood experiences and the development of his personality in general. And I would definitely have a clinical focus on the development of obsessive compulsive personality disorder. Yeah. He's very meticulous. He's very morally rigid when it comes to his value system. He certainly aligns with OCPD, which only requires, I think, 4 criteria. It's a relatively low threshold. I also don't take him as someone who can macromanage or delegate responsibility to others. Now, we don't see him work well with others in any capacity, really, but the idea of him delegating and not being that micromanager, I'm not so sure we'd ever hope to see that. So obsessive compulsive personality, certainly antisocial personality, if not traits. Delusional disorder, grandiose subtype. Anything else for John Doe? Other characters, David Fincher, Se7en.
Why does it talk about Mills himself?
Mills? Observations on Detective Mills.
I think he's a flawed character, for sure.
Can you ever see Mills, forget his personality style and whether he'd want to or not. From a clinical perspective, can you ever see him in a psychiatrist's office? Like I guess Zen knows. Let's go with yes. Now, again, I think that there's enough there where if presented to him, the answer is going to be a definitive no. But let's address the question along the lines of whether or not there's anything there that we could be of assistance. If he were to show up right next door here, what do you think his treatment plan would be? Other than the fact that, Doc, I don't need to be here. I need to get back on the force. My CO sent me here for some type of evaluation so I can get my gun back, get my badge back. Right? That's probably going to be the context, but despite that, how can we help him? And again, we know his medical record, everything we understand from the movie. Right? We've seen what we've seen, and that's now going to be provided, that information is provided to us in the medical record, the referral.
Anger management and emotion regulation.
Right? Mm-hmm. So that biopsychosocial treatment plan is going to include a referral to therapy to start, and with the recognition that there are no FDA-approved medications to address that on the treatment plan. Could the anger management issue or the anger issue be in the context of a larger disorder, and if so, what's your differential diagnosis?
I mean, irritability could be seen in a major depressive disorder.
Mm-hmm.
It could lead to like mood swings and outbursts.
Yeah, it could be depression. It could be bipolar. It could be a manic state. It certainly could be. Mm-hmm.
Could it also be maybe a borderline personality disorder?
Could be borderline personality disorder, and certainly could be borderline PTSD spectrum. Mm-hmm. I think that would be the top of my list. All right. Any other supporting evidence that would point us in a particular direction here, given that differential? So let's start with the one that I think be concerned with the most, and that would be a manic episode. Because if that's true, we may have to think that the provision of care should be at a level that's no less restrictive than an inpatient unit. So that's got to probably jump the line here. So we're concerned that there is a discrete episode hallmarked by irritability, which then would be a necessary, if not cardinal feature of a manic episode and therefore bipolar 1. Now we have to look at the other signs and symptoms to see if he reaches 4 additional, right, for a total of 5, right? So what defines a manic episode, and does Detective Mills demonstrate them?
Hyperactivity.
Hyperactivity.
Decreased need for sleep.
You ever see him sleep? I think he's at one time on the stool on that bench. Didn't really sell me that he had a good night's sleep there, but
Pressured sleep.
yeah. Mm-hmm.
So the thing I noticed is like he also engaged in a lot of like substance use, like alcohol consumption as well
Mm-hmm.
throughout the movie.
Bipolar does have a high comorbidity, and it's noted to be number 1 among mental disorders with regard to substance use disorder, and that's at about 60%. So that would be consistent. Right, distractibility. So the acronym is DIGFAST, and he might actually have 4 additional symptoms. That's something we probably should consider. What else on Mills? If he doesn't rule in for a manic episode, and we're looking at the other differential, I think right next would be depression. Irritability could be a replacement for depressed mood, as the cardinal feature required 1 question screen to assess for the other neurovegetative signs, SIGI caps. Anything there? I think less so than DIGFAST, than the manic episode. And then if not that, then we're looking at a personality disorder, and maybe borderline personality. So here you need 5 total. Let's go through the diagnostic criteria first, and then we'll see if he rules in here. So this, unfortunately, that is borderline personality, unfortunately, is not a personality disorder that has a cardinal feature. So we can't just remember, okay, that's what it looks like, and then the criteria are just manifestations or examples of that cardinal trait. That's absent here. So we really have to review the diagnostic criteria here, right? So let's start off with mood reactivity. Do we think that our detective is mood reactive? Is he labile? Does he suffer from mood swings? Yeah, okay. Is anybody saying no here? Right. Right. So that's unfortunate, because we think the next step, even though we're going to derail just a little bit from going down that list of diagnostic criteria, to consider that there might be a maladaptive defense mechanism here that's in play. Not only would it be considered to not be a mature defense mechanism, but its rigidity may result in clinically significant distress or impairment in his functioning. So what defense mechanism do you think we'd have to consider examining here? What defense mechanism usually manifests with mood reactivity? Splitting? Right. Splitting? All or nothing thinking? Will lead to an emotional roller coaster. And again, splitting in and of itself is not that big of a deal. If you had split 2 weeks ago from 4 to 4:15 p.m., okay. All right. However, when it becomes rigid and it becomes a part of your personality, that's a risk factor. There's your risk factor, and that might be in play here. All right. Impulsivity or difficulties with impulse control. Mills, yes or no? He might be the number 1 Hollywood character ever created to demonstrate impulsivity. Do you think I'm missing a character that you would put above him on that list of the most impulsive ever created? And here's why. If it weren't for his impulsivity, John Doe would have never chosen him. So it really is the core to understanding this movie. Right? He had to be impulsive. He had to pull that trigger at the end. That's what this movie's about. It's about Mills's impulsivity. And no other movie gives you that. Okay. Suicidal thoughts, suicidal gestures. Anything there?
Maybe after the movie.
Yeah, I'm worried about him in the sequel. But unfortunately, well, fortunately, the answer is no today.
Seven has a sequel.
Was that?
Seven has a sequel.
No, make it up.
Oh, made up sequel. Got it, okay.
Self-image disturbance. No, I'm not getting it either. Okay, so dissociative episodes or episodes of stress-induced psychosis.
Not during the movie.
Nah, I'm not seeing that either. Interpersonal dysfunction. A nod, a definitive nod, and a definitive nod with a smirk. Yeah, okay. Episodes of anger.
A little bit.
That was quick. I finally got you guys awake. Chronic feelings of nothingness.
Nah.
Yeah,
I mean, it's drinking, I guess, but like, not delivered.
is that?
Not as prominent, that's one of the
Yeah, I mean, it's one we might want to just consider going back into the room and asking him about.
It's not clinically significant.
Yeah.
Just based on what we see in the movie.
Abandonment issues. Yeah, that's another one that I'm going to have to go back in the room and ask him. So my initial inclination is no. Not 100% sure, but we keep that in our short list as well. I do want to go back to the dissociative episode, and because remember when he shot the guy who was hunkered down in his apartment and how he described it? Didn't he say that he went numb? Again, that's acute trauma. I mean, that's in the acute setting, and I'm not suggesting that I've observed anything in the movie to suggest that it has been protracted. But I'm almost sure he described it as a form of numbing. So that is another one you definitely put on the back burner, and it would not surprise me if, in the interim, he had those feelings. That would not be surprising whatsoever. So that one's a little high on my list, and we're at 4, and all we need is 5. So he's close to ruling in for borderline personality, and that's only through behavior demonstrated in the hour and 50 minutes that we see him. Okay, so something to consider here for Detective Mills. Anything else with him?
maybe intermittent explosive.
Yeah, so conditions like intermittent explosive disorder form a group of disorders that were previously classified as impulse control disorders. Pathological gambling, now known as gambling disorder, was actually removed from that list, from that chapter, and recorded in the addictive disorders chapter. And then trichotillomania was itself removed from that chapter and put in the obsessive compulsive and related disorder chapter. So the chapter's kind of small now. They did absorb a couple of childhood illnesses, which we're not going to discuss today. So there's 3 adult illnesses to consider here. The initial consideration is intermittent explosive disorder. And even though he doesn't really demonstrate signs of the other 2, for completeness sake, for a board review, we probably should review them first. So in addition to intermittent explosive disorder, what are the other 2 adult psychopathologies that are classified in this chapter?
DNPD.
Kleptomania and pyromania. Right, kleptomania and pyromania. Again, it's 5 total now. 2 are child, adolescent, and onset. The 3 adult are pyromania. kleptomania, and then intermittent explosive disorder. What is pyromania? Fire setting, right? It's fire setting that results from an uncontrollable urge to act on an impulse, right? And because it's an uncontrollable urge, it's motiveless by definition, meaning that if you find motive, it isn't pyromania. So as soon as you see that the fact that the house burned down or the business burned down, and now the insurance is going to pay out, the psychiatrist needs to transfer the case to criminal justice. Okay. Similarly, kleptomania is what? Stealing. Yep, that without motive, right? It too, by definition, is motiveless, meaning that if the individual keeps the item of value, again, that's not going to be kleptomania. Right? Those items are usually of no value and usually discarded, despite their value, or despite what they're really worth. Right? Motiveless behavior, inasmuch as it's an uncontrollable impulse or action on an impulse to set fires, to steal. Then we get to the intermittent explosive disorder, which is exactly what it sounds like. Now, there's a caveat here, very similar to what we just discussed pertaining to the other two conditions, and that is if the intermittent explosive nature of one's behavior is better accounted for by a larger disorder like mania. We do not diagnose intermittent explosive, even as a comorbid condition. For instance, and I think at the very top of the list would be antisocial personality disorder. Individuals with this condition often have intermittent explosive acts towards people. So we wouldn't say that then therefore they have intermittent explosive disorder, they have antisocial personality. So thoughts with regard to adding this on as a secondary diagnosis, or does the team reconsider and think that those acts are likely contained or explained by another healthcare condition, another mental disorder? It does heighten my suspicion of mania, and borderline with anger. I mean, unless I could reach out to his therapist and have them tell me that he's been going to DBT as scheduled, and there is a significant reduction in symptoms, and that any residual signs might be due to another condition. We'd have to consider this may be part of borderline personality, if not antisocial too. So that's the way I would actually go about that particular behavior. 5 minutes. Any other characters? 7. We're good? Leave it here? All right.